So this is a really amazing honor and privilege. This has been a room of nostalgia and getting to remember the good old days. So I'm just thrilled to kind of be invited here. And by the way, on the conversation, I had 3 60-year-olds in my clinic this week talking to me about TAVR versus SAVR, 61, 65, and 68. So I know this conversation very well, and it is a very tough one. So just to add 2 comments, I think valve size, TAVR valve size, I think it's a huge play. If you only can get like a 20 or 23 and a 61-year-old, I think getting maybe root enlargement and kind of a surgical approach. And then the other thing is, mechanical valve, 61-year-old Onyx, target INR 1.5, 2.5. My 61-year-old lady that came to see me, I was pushing her towards kind of the Onyx discussion. So, but anyways, do I hit next? Sorry, forgive me. All right, thanks. So Neuro Protection, I'm a believer, so you're going to kind of get that bias here in this presentation. These are all my captures. These are varying size of shotgun that we were able to catch. These are all Sentinel, of course, devices. But the data is not so far kind of boring out, and that's what I want to talk about. So this is kind of the very quick pathway I want to take us through. Stroke is on the decline in TAVR. I think that this is a reflection of many things, but Sentinel protection is, I think, part of this equation. Lower and lower risk patients is also part of it. Stroke is really bad. That's what this slide basically says. You have a stroke, mortality is higher and higher. So I will not go through this, but this is actually a very important slide. Ischemic, hemorrhagic, TIA, understanding the definitions, especially disabling versus non-disabling, not only to the patient, but also to the healthcare system about how these patients kind of do long-term. Subclinical is also something very important to emphasize. These patients supposedly, do well, okay? They don't have major symptoms, but it is a very smoldering, long-term cognitive decline that can happen. And this slide, forgive me, just because it's a little bit smaller, but this is to emphasize that the event of stroke is very early on. You can see the curves rise rather quickly and then start to plateau. It is in the first day to 3 days. There is kind of this procedural day stroke, and then there's this delayed 48, 72-hour stroke that can still be related to the procedure. And then just as far as subclinical stroke, there's a over 2 times risk for dementia development for subclinical, quote-unquote, asymptomatic stroke. So just a long list of the cerebral protection devices that are coming around, being developed. Sentinel is far and away your huge pie of the cerebral protection devices. TriGuard is kind of the next up-and-comer. These are just the different protection capabilities of the different cerebral protection devices. The top left 2 are the top left is the Sentinel, okay? You have 3 out of the 4 cerebral circulation arteries protected, and you have to use the right radial. TriGuard is 4, and it comes from the femoral. And then you can see basically you have different varieties of not only the cerebral protection, but also even distal protection, renal, mesenteric, etc. So the first kind of trial that showed some favoritism, but not boring out to be proving the primary income, was the IDE for Sentinel. This is all now Sentinel data. What you see here is that The device cohort did have a trend towards protection, but this was not proved to be significant. And then you have your protected TAVR. This was in 2022, 1,500 patients in each arm, and you see the same trend, but again, not significant. The reason that they felt this was not significant was that they got a much lower stroke rate. They were expecting a stroke rate of 4%, and they only got 2.9%. Now, the disabling stroke actually proved to be significant, but this was a secondary endpoint, and therefore thought-generating, hypothesis-generating for future trials cannot take it to the bank just yet because the primary endpoint was not met. This is the mother lode right here. So this is out of the UK, BHF Protect TAVI. They're enrolling over 7,700 patients. You can see the red line is actually their enrollment is beating their projected enrollment. So they originally projected to publish in 2026. This may be early 26 or even late 24. So this would be really awesome. This is meant to power that 2.93% stroke rate so that they can hopefully prove the benefit of cerebral protection. So this is enrolling, I think, rather quickly and is promising. And again, it says 72-hour primary endpoint of all stroke. So in TAVR, for our time being, we're in who to use cerebral protection for, or at least think about it. Your bicuspid patients for sure, valve-in-valve cases, heavily calcified, your higher calcified score risk patients, the aorta as well, as you're coming across the aorta, heavily calcified porcelain aortas. And then this is not well talked about, but I've definitely seen this bore out to be true. If you're needing BAV, I really highly think that they should have some cerebral protection. And especially if you're going to have to, it's going to be a very tight, say it's a critical aortic stenosis, you're going to be wanting to do pre-BAV. We don't do this as routine as we used to, but sometimes we do need to. Then think about embolic protection. The other thing that I want to highlight here is it's hard to predict which patients are going to need post-valve deployment optimization. Who are you going to BAV post-valve? And the BAV post-valve definitely is calcium destabilizing and ripping through even the old leaflets, sending them northward. So heavily calcified, these are cases to avoid cerebral protection. In my practice, this doesn't happen very often. I think less than 5% of the time, we're not able to offer cerebral protection, but heavily calcified subclavian arteries or the carotid arteries, tortuous aberrant subclavian, for whatever reason, unsuitable right arm anatomy, if we're talking about sentinel specific. And then the need for coronary protection, this is obviously debatable, but if you're needing your catheter to protect the left main, that's one source or one access that you're kind of using up. And then in my conclusions, cardioemboli have significant potential for harm. I think that is an understatement. Current CEP devices do appear safe. I didn't go into the safety, but they did not increase the risk of stroke. Newer devices are being studied for different access sites, different degrees of embolic protection. Larger studies are ongoing, like I mentioned, and in patients that are high risk with suitable anatomy, I think CEP should definitely be considered. Thank you. Did I make it?